So thank you so much once again for the wonderful talk. I think we can relate that how many people wanted to ask the question that this is the topic of interest at the moment. But due to the time constraints, we have to move to our next scientific session. And our next session is Micropenis and Delayed Puberty, a comprehensive approach to diagnosis and treatment. And for that, I will request Professor Jamal Raza, who is a pediatric endocrinologist, and he's a head of department, Institute of Child Health, Karachi. Thank you, sir.
Assalamu alaikum. Thank you very much. I'm really honored to be here and proud to be here. Can I have the first slide? It has a little bit of introduction. So, right. So currently I'm the Executive Director of Sindh Institute of Child Health and Neonatology, and I'll take you through that in a minute. I'm also President of Pakistan Pediatric Association, President of South Asian Pediatric Association and Endocrine Society, Pediatric Endocrine. But the most important distinction here is that I'm the founder and the life member of Pakistan Endocrine Society, and two of my colleagues are sitting here. So really honored to be back to the PES forum and sharing something with you. So, sorry, a little bit of digression here. Before we go to my topic, I'll take a minute because I want to share with you what we are doing in Sindh with the Sindh Institute of Child Health and Neonatology, because it's a very important initiative taken by the Sindh government in the last couple of years, where we are, providing child health to a large segment of the society. So this was established with the Act of Parliament 2019, and we started our first hospital in Korangi. So let me show you a little bit of glimpse of what we are doing in Korangi. So this is a pediatric hospital, 200 bedded, that we have established. Do we have sound here? It's okay. And this is with an intention of providing care to the pediatric ICU and neonatal ICU in particular, but we are having all the disciplines like the endocrine, neurology, pediatric nephrology, pediatric rheumatology, and then very soon we are going to start the pediatric surgery. So this is an initiative which is providing free of cost medical treatment, and we've only started about 2022. So it's about a year, and we have provided treatment to over 100,000 children at this facility. Our next stop is at Sakhar, where we have started about 200 bedded children hospital, which is the largest children hospital in the upper part of the Sindh. Fortunately made by the Korean government, but we have started the outpatient, and then we plan to expand this hospital to a full-fledged hospital. So currently we are based in Karachi and Sakhar, but over the next couple of years, hopefully we are going to extend to Mirpur Khas, Shikarpur, Ladkana, Kambar, Shaheed Benazirabad, and we are also doing service, starting service at Sobraj and UHC Azam Basti and Dr. Tasneem. We are also supporting the JPMC Gynae Ops department and have our team there. So now coming to the topics, the delayed puberty and the micropenis. The basic pathway is very simple. From the 6th week of embryonic activity, the GnRH neurons begin migration from the olfactory plico to the arcuate nucleus under the various genes like the anosmin, the CAL1, the PROK2, FGF8 and FGFR1 and CHD. And then by 15th week, the development of the hypothalamus and the gonadotropin at puberty is complete under the influence of SF1, DAX1, PROP1, HSX1, LHX, LHB, LHR, FSHB, and FSHR. And then the pulsatile gonadotropin binds with the GnRH receptor at pituitary, and the influence there is GnRH gene. And in one of the studies that was done in Lahore, where 50 hypocs were evaluated for their gene involvement, at least 2 novel mutations have been found with this GnRH gene. So But this is just a beginning. One of the recent paper that has been published in 2023, done a study done by the Agriculture University, which reviewed the genes involved in the normal and the delayed male puberty, have identified that about nearly 600 genes were involved in the development of puberty. And out of those, they have found that 75 genes, mutations have been found, which are responsible to disrupt the male puberty. So it's been very extensive. And as you can see, the genes are now getting more and more extensive and involving every area, starting from the hypothalamic development to the regional territory development, neuron differentiation, GnRH neuron migration, hypothalamic neuron development, synaptogenesis, GnRH synthesis, gonadotropin synthesis, development of the testes, and the steroidogenesis. So, of course, the area where the genetic influence and the subsequent possible intervention is now on the cards is becoming more and more extensive. So let's start with the definition of micropenis. And micropenis is something which is structurally normal, but abnormally small penis, which is defined as the stretched penile length of -2.5 standard deviation below the mean for age and sexual stage. The fetal androgen, of course, are high between the 8th and 24th week of gestation, with the highest in 14th and 16th of week. And there is a significant increase in the penile length between 16 to 38 week. So if there's something that is going wrong from the 12th week of gestation, then there is a hormonal abnormality that is likely to result in micropenis. There have been various studies across different countries which is looking at the stretched penile length, and although the cutoffs vary, but somewhere around below 2 centimeter at birth and below 4 centimeter after 5 years of age is considered to be micropenis. However, there are various variations that comes to a clinician's attention, and a number of times when children are referred, especially in the newborn or in the infancy, with the complaint of micropenis, they are not actually micropenis. I've used the word pseudo-micropenis because they can mimic the micropenis situation. And as you can see, the webbed penis is a condition where there's a web or a congenital fold which obscures the angle. And the appearance is that of micropenis, which often worries the parents. So the physician treating should be aware of this webbing, and there is also a classification which is more for the surgical correction, but a webbed penis can look very much like the micropenis, whereas the corpora is pretty much normal, and that will make the difference. Another variety is the buried penis, which can present at about any age, starting from the newborn in infancy, anywhere in the childhood, but more often than not, we are now seeing it around just before the pubertal time, somewhere around 10, 11 years of age, because obesity is getting more and more prevalent. And this is where, it engulfs the whole penis and it takes it into a situation where sometimes the whole penis gets buried. And that really, and because the puberty is not started, the size does not begin to enlarge. And that's what worries the parents a lot. And they often bring this saying that this child has got problems with the puberty, there's some hormonal issues, where in essence, this is just a buried penis. Similarly, you can have a trapped penis because of the entrapment with a scar tissue, and sometimes there's a chordee, which is basically a curve and not the true micropenis. So it's a medical diagnosis which is often made incorrectly, and thus a misdiagnosis can result with a lot of parental anxiety and lead to unnecessary examination as well as investigation. So it's very important for the treating physician to be absolutely sure when he or she is truly dealing with micropenis, and maybe use one of these charts which actually tells you about the size of the penis, taking into consideration also when the child was born, whether it's a term child or a premature child. Also, you need to very carefully measure the stretch penile length and use maybe a ruler or a caliper to measure the penile length. It should be measured with the penis fully stretched and not flaccid. The glans should be held with thumb and forefingers and a measurement taken from the pubic ramus to the distal end. And of course, you need to push the suprapubic fat a little back so that you can avoid the fat that is around, and that may be again affecting the size of the penile length. So one of the studies that has come from the neighboring India published in June 2023 says that something like an SPL of 21 millimeter in a term male newborn and 17.5 in a preterm should be considered micropenis. So you should be aware about the cultural variation in the size of the penis as well as the age and the standard deviation, as we have mentioned. So how do we evaluate that? We of course take into account the family history of the siblings. If they have similar problems, we need to make sure that the child was born prematurely or born at term. We need to, during our examination, be careful about the midline defect, any features of panhypopituitarism, which can then also affect the penile size, presence and location of the gonad, and often if there is a cryptorchidism or the undescended testes or a hypospadias. There's also such a thing called as mini puberty, which happens in the first and third month of life with the activation of the GnRH pulse generator with the surge of FSH and LH, and that gives a raised testosterone and inhibin and AMH at that time, which is responsible for the development of the male sexual characteristics. So now coming to the delayed puberty, by definition, the delayed puberty happens when there is no breast development in a girl by the age of 13 years or no menarche by the age of 16 years, or the testicular volume in a boy is less than 4 mils by the age of 14 years. You must be careful that this is not affecting the adrenal and pubic hairs, because they may be present as the adrenarche has a separate presentation and separate reasons for the adrenal pubic hairs. So they may be present and they may not be affected in a true case with delayed puberty. There has been data that is coming out over here and internationally as well, which is pointing towards shifting of the age of the onset of puberty. And, there are signs that there are early onset of puberty both in boys and girls. However, the evidence is not enough and not so robust so as to shift the definition of delayed puberty, which still stands as mentioned earlier. So when we look at and of course we sometimes get arrested puberty, where the puberty may start and then it doesn't progress. So if we look at the conditions, the various types of the delayed puberty, then they can be divided into 4 major areas. The first is the hypergonadotropic hypogonadism. The second is the hypogonadotropic hypogonadism. Third is the constitutional delay of growth in puberty. And the fourth is the functional one. So if we look at the hypergonadotropic hypogonadism, of course, the problem lies in the gonads. If you look at the acquired list of causes of the acquired causes, then they are pretty self-explanatory, where a damage to the gonad is done, as in the mumps, orchitis, or radio or chemotherapy, tumors, medication, autoimmune, galactosemia, etc. Or there are congenital reasons like Klinefelter syndrome, Turner syndrome, Down syndrome. There may be gonadal dysgenesis, enzymatic defect, gonadotropin resistance, anarchia or vanishing testes syndrome, and some of the genetic causes can happen in the hypergonadotropic hypogonadism. So the evaluation, of course, look into the history, the causes that are mentioned as the acquired causes. And in the examination, you look for the features of Turner and Klinefelter and presence and absence of the testicular tissue. The Yadunaki, as mentioned, can often be present. So some of the features of Klinefelter syndrome, they are taller than the average height, they have reduced facial and the body hair, they have a breast development like gynecomastia, osteoporosis is there, and they have a feminine fat distribution with a smaller testicular size. Whereas in the Turner syndrome, often the presentation is that of a short stature, but they have features like the low hairline, the shield-shaped thorax, wide space nipple, small fingernails, but the ovarian failure is the one that results in the delayed puberty and subsequently no menstruation. If we look at the hypogonadotropic hypogonadism, then the acquired causes are straightforward. They are probably responsible for the damage to the pituitary, like tumors, craniopharyngioma, germinomas, cyst surgery, radiotherapy, traumas and infiltrative lesion and CNS infections. And then we have congenital causes where there may be problem with the multiple pituitary hormone deficiency, various genetic syndromes like Charge and Prader-Willi, isolated hypogonadotropic hypogonadism like in Kalman syndrome, which is associated with anosmia, and then normosmotic congenital hypogonadotropic hypogonadism, which, as mentioned previously, has a large number of genes that may affect and influence the development of the hypog. The history and examination, of course, is directed towards the primary cause, and in the examination you look for all the features that mentioned, like the micropenis, cryptorchidism, anosmia, cleft lip palate, renal anomaly, skeletal anomaly, dental agenesis, and bimanual synkinesis, which is the mirror hand movements. Constitutional delay of the growth and puberty is often the most commonly seen as the cause of delayed puberty, which is more common in boys. Initially, it was just thought to be a constitutional or a normal variant. However, a number of genes are now involved with the constitutional delay of puberty. The important thing is that you will not have any features of any syndromes, and they are generally present and associated with growth delay. And of course, there's a family history, of course. So this is a typical growth chart where the child may continue to grow on the normal lower centile and then falters the growth around the time of the puberty, which is consonant with the delay in puberty and growth, as the name suggests, and then subsequently goes into the puberty and completed the final height. Some of the data that has been published recently have shown that the most common cause of delayed puberty is the constitutional delay in the puberty. This is also published in 2023 August, one of the large multicentral trial from the UK, which has shown about 66% of patients suffering from delayed puberty. One of the trial, I think, is not here, was published from JPMC by the team of Professor Tasneem, where they had about 171 patients, and delayed puberty came out to be the commonest cause. Then the last functional hypogonadotropic hypogonadism is as a result of the number of acquired conditions like inflammatory bowel disease, celiac disease, renal failure, restrictive eating disorder, acute illness, drug and endocrinopathies, including hyperprolactinemia, hypothyroidism, and diabetes. So you look at the systemic illness history and you look at the likelihood of underweight and growth failure. The first line investigation are often basal, FSH, and LH, which of course will differentiate the primary hyper and the hypogonadotropic types along with the bone age. GnRH stimulation test is often done but is not really conclusive. The other investigation would include the karyotype, pelvic ultrasound, celiac disease workup, thyroid hormone workup, and serum prolactin level. Imaging is only done if there are signs which are pointing towards intracranial pathology. So something which is not easy to differentiate is the constitutional delay versus hypog. As mentioned, GnRH stimulation test can be done with 100 micrograms of GnRH and looking at the LH level subsequently, but it's not really discriminatory. There have been studies published which are pointing as another alternative is the inhibin level. A very low inhibin level of less than 35 is not seen in constitutional delay, but there is a considerable overlap in the individual level between the hypog and constitutional delay. Two of the other tests that have been now identified is the FSH stimulated inhibin level, and this is the cutoff. But the most reliable is the kisspeptin 54 stimulation test, which is nearly 100% distinguishing between the hypog and constitutional delay. And if you want to assess the testicular function, then HCG stimulation test is done in the manner that is described here. Of course, with so many genes are now being involved, it's important to look into the genetic testing to further investigate the hypog cases. So this is the kisspeptin test, which is fairly accurate. So now if we look at the schema of how do we look for the constitutional, how do we approach the delay. Can we have the pointer here? It's a little busy slide, sorry. How do we approach, is my pointer? Okay. So, so if there is no testicular development in a boy by the age of 14 years, you look at the thyroid profile, systemic illness, and poor nutrition. If that is there, then you treat. If the bone age is delayed and there is no pubic hair and the basal basal LH is more than 0.3, although it can be less than 0.3, then it is more likely to be constitutional delay, and you just monitor and continue for the progress. If there is pubic hair present and the bone age is normal, you do the GnRH stimulation test. If there is a pubertal response, then it's fine. If it's a prepubertal response, then it is probably hypog, and you proceed with MRI if it is required. If it's an elevated FSH and LH, then you do a karyotype with Klinefelter, then it's straightforward. If it is XY, then you need further evaluation like the genetic testing for gonadal dysgenesis, for the testicular biosynthetic defect, or autoimmune conditions, and the other reasons. So if it's a girl and it's a delayed puberty in an adolescent girl, if there is no thilarchy, then the approach is pretty much similar in this part. But if it's an elevated FSH and LH, then you do the karyotype analysis. If it's an XO, it's a Turner syndrome. If it's an XY, you need to look for the CAIS or gonadal dysgenesis. And if it's a 46XX, then it is genetic testing for the XX gonadal dysgenesis and evaluate for the biosynthetic defect. If there's no menarche in a 16-year-old girl, and if the thilarchy is present, then you look for the genitalia. If it's an abnormal genitalia, it's an XY-DSD. If it's a normal genitalia, then you look for complete androgen insensitivity or MRKHS. So how do we treat that? If it's an infant, then we need to reposition the testes in the scrotum by the age of 12 months. You do the orchidopexy, and before the orchidopexy, sometime combined gonadotropin therapy is required. For the micropenis, you may give a short course of testosterone therapy to induce the penile growth. You can give 25 milligram 3 weekly for 3 months. Because the treatment is restricted for a short duration. There are no concern about virilization. Alternatively, a topical gel may be used, which also produce good effects. In special cases, like especially in 5-alpha reductase deficiency, dihydrotestosterone may be used. There have been some reports for the use of recombinant human FSH and LH. The first reports were published in 2002 and subsequently in 2008. And more recently in 2017, where a single study was done for 6 males with micropenis, there have been a significant increase in serum testosterone, stretch penile length, and therefore it was concluded that this is a safe and well tolerated and effective treatment for the treatment of micropenis during early infancy. However, it's not something that has been adopted mostly, but there are studies that are supporting it. Should we treat the constitutional delay or should we wait? Earlier there was a consensus, or there was a thought that it need not be treated. However, there's some recent data that is coming in that is saying that it may adversely affect later on, and there are some adult consequences of not treating the self-limited delayed puberty. So perhaps, especially if there is a poor self-esteem and a body habitus problem or a short stature problem, they may be treated with testosterone esters. You can use transdermal and intranasal testosterone. And as mentioned, exogenous, it does not include the testicular growth nor promote the spermatogenesis. The girls may be treated with estradiol. If it's a long-term treatment beyond the constitutional delay, then of course the treatment need be continued 4 weekly initially for the 50 milligram and then subsequently increased every 4 weeks every 6 months till you reach the full dose, and similarly ethinyl estradiol in a dose of 2, 4, 6 and 8 microgram is used for girls, and a progesterone is added after 2 years of estradiol. Sometimes you also need to treat them with gonadotropin because of the increase in the testicular size, which gives a better outcome. So in summary, a correct and timely diagnosis of micropenis should be made appropriately to avoid unnecessary investigation. Delayed puberty should be evaluated for both systemic condition as well as endocrine problems. Constitutional delay should be treated with a short course of medication when indicated. More thorough investigation should be carried out, especially in cases of hypog, to look and evaluate for other pituitary functions. And a long-term treatment for replacement need to be planned and discussed with the family, especially for the later issues like fertility and pregnancy. Thank you very much.
Thank you so much for an excellent presentation. I think we have got a time for a few questions. So any questions, please?
Professor Jamal, Raza, first of all, thank you very much for excellent talk. My question is, in patients with constitutional delayed puberty, you did mention there's some studies, some data to treat them early on with testosterone.
Yeah.
And this is now, we're not talking about priming them for micropenis, rather giving them testosterone in higher dose than that. So what are the implications of that on endogenous suppression of gonadotropins and for the future height potential on these subjects?
I mean, the dose that we use to treat the constitutional, which is a 50 milligram dose, is a very small dose. So it does not affect the natural progression of that child into the puberty. So it does not suppress the gonadostat and does not reduce. So in potentially, and then you treat them for 3 months maybe then and stop and evaluate for their natural progression. And generally in 3 to 4 months, a small dose will, for the constitutional delay, will start off the natural progression of the puberty, and you do not need to subsequently continue with that. Their growth, of course, once the short stature or the growth delay that is happening during that time is primarily because of the lack of the pubertal hormones. So once you have the pubertal hormones on board, by the stimulation of the natural or start of the natural puberty, then the short stature issue is also resolved and they generally attain the normal height potential.
So I just wanted to clarify that usually 25 to 50 milligram of testosterone is like a priming dose in young adults or adolescents. So and we use it for 3 months or so. Sometimes maybe that stretch can be 6 months. So pretty much the same regimen you are talking of using for constitutional delayed, right?
Absolutely.
Thank you.
Thank you, Professor Jamal, for a really wonderful talk. Really enjoyed all the session. So my question is that which tests are available to us? So you mentioned inhibin B and kisspeptin stimulation tests for CDGP.
Those unfortunately are not available at the moment to the best of my knowledge. Kisspeptin certainly is not available. So I think for the all practical purposes, we are using the morning LH and testosterone level along with the clinical information. As I mentioned that in cases of constitutional delay, you don't get other signs of any syndromes or anything else. So they generally present with pubertal as well as the short stature. And then if you have the basal level of LH and testosterone to guide you. Sometimes you can do the GnRH stimulation test, but as mentioned in an individual case, there is a great variation. So you may not be, it may not be discriminatory for an individual case. If you're talking about a cohort, then maybe it's different, but if in an individual case, it may not be discriminatory.
Okay, so but then there will still
and then
be a
the bone
risk,
age delay, is also important. Yes.
there will still be a risk that CDGP might be mixed up with an hypog patient. In that situation, my question to you is that the natural progression to puberty in a CDGP, what is the age limit where you would expect that the CDGP will now naturally progress to puberty?
The cutoff, of course, is 14 years, and by you use the testosterone induction for about 4-6 months, maybe you stop, reevaluate them for their progression of puberty, and then reinvestigate them also. And if you feel that after 3 to 6 months of giving a small dose, and then maybe stopping for another 3, 4, 6 months, there is no progression into puberty, then it is very likely that they have a hypog situation.
Okay,
then you may need to continue the treatment for a longer time.
Thank you.
Assalamu alaikum.
Assalamu alaikum.
I'm Dr. Hassan, PGR endocrinology. My question is this, sir, if a child came at the age of 12 years or 13 years, and how we decide it is hypogonadotrophic hypogonadism or it's a constitutional delay? Because at that time, if you order FSH, LH or pituitary hormone, that axis may not be started at that particular age. How we will decide that it's constitutional delay, or we label it as a hypogonadotrophic hypogonadism?
12 or 13 is too early. By definition, we are talking about the age of 14 years. So I think 12 or 13, you don't need to investigate. You just wait and tell them that, it's still early for the child to be labeled as delayed puberty. So maybe till 14, if they have not gone into puberty, then you need to investigate them and, as mentioned, try to differentiate between the hypog and constitutional. And if you don't get a clear answer, maybe treat them for a few months and see what is the response.
At that window period, we just reassure the family?
Yes, you reassure the family.
Okay,
yes.
Thank you.
Assalamu alaikum. Thank you very much for an excellent talk. I'm Professor Amir from Shower. We usually use testosterone for patients who've got hypospadias, and then the surgeon is intervening, and then we use it for that before they go for surgery. Do you think there's a role here as well?
Yes, I have mentioned testosterone as an alternative to using a small dose of testosterone injection. So they have both have been used and used to a good effect. So they are pretty much the same. It's also a matter of individual preference and experience as to which one you have used and found good results. But in literature, they have both been used. I personally not used Testrogel. I think Dr. Sneem has been using them for some time because it's just a matter of which one you get more confidence on as far as, but they are both effective.
Yeah.
If you have a DHT, then also that is a very effective cream.
Right. Would you comment, because you've been using it? Just
I
for
have
clarity.
not been using it in children.
No.
I have used them in, I don't treat children. I've used it in grown-up people with this, with good results. Some people really like it, and there are some who just completely refuse to accept that mode of delivery.
Thank you.
Thank you.
Thank you so much. Can I request Professor Abdul Jabbar to collect his certificate of appreciation from Professor Tasneem, please? Dr. Jamal Raza, sorry.